Disparities in healthcare exist across racial groups, with disease prevalence and treatment outcomes seemingly influenced by race. The U.S. government considers there to be 5 racial categories: American Indian or Alaskan Native, Asian, Black, Native Hawaiian Pacific Islander, and White. While Hispanic is often an included category when evaluating racial differences, it is considered an ethnicity by the U.S. government rather than a race. With only 5 defined racial groups, each of these consists of people from broad geographical backgrounds. For instance, the U.S. Black population is made up of people from North and South America, Europe, Africa, and the Caribbean, to name only a few. The U.S. Asian population is made up of people from diverse places such as China, Philippines, India, Vietnam, and Malaysia, while those from Iran, Egypt, Syria, and Morocco are classified as white. The categorization of people into these groups depends on the assumption that there are both similarities within racial groups and differences between them, though this may not always be true. In fact, the Human Genome Project found that the genetic variability within racial groups is greater than the variability between them, and determined that race cannot be considered a genetic category. Another consideration when looking at racial differences is how a person's race is determined. So, who determines racial groups within this diverse population of patients? A 2004 study found that information about patient race and ethnicity is collected from many sources through various means. While patients or caretakers frequently self-identify based on forms provided by the clinic, racial identification is also often determined based on observation by the admitting clerk or the healthcare provider. This leaves the determination of race in an ambiguous and subjective territory. Knowing that race is an artificial categorization, it is still useful in evaluating healthcare disparities because race has historically been used to rationalize and perpetuate inequality. Healthcare racial disparities reflect differences in health behaviors, clinical care, and social, cultural, economic, environmental factors. By understanding these modifiable factors, we can decrease healthcare disparities and improve healthcare for all people. While hypertension affects patients of all races in the U.S., it is not evenly distributed across racial groups. According to the CDC, approximately 58% of non-Hispanic Black patients live with hypertension, a significantly higher rate than other racial groups. This trend continues when looking at those treated with medication but who continue to have uncontrolled hypertension. Generally, uncontrolled hypertension is defined as blood pressure above 130/80 millimeters per mercury, despite taking antihypertensive medication. For example, 55% of non-Hispanic Black patients who are taking medication to treat hypertension have uncontrolled blood pressure, the highest among the included groups. A large percentage of those with uncontrolled hypertension have stage 2 hypertension, increasing their risk for complications such as heart disease and stroke. To offer the most effective treatment, clinicians follow the International Society of Hypertension Global Hypertension Practice Guidelines, recommended by the American Heart Association and the American College of Cardiology. While all patients with hypertension are recommended lifestyle modifications, 4 out of 5 adults are also prescribed medication to further control blood pressure. In those patients who require medication, the guidelines initially indicate monotherapy with once-daily dosing, usually a thiazide diuretic, calcium channel blocker, ACE inhibitor, or angiotensin receptor blocker. For over 2 decades, there has been a difference in the recommended initial monotherapy for Black patients compared to all other patients. This was first based on findings from the ALLHET study, in which there was an apparent advantage of thiazide diuretics and calcium channel blockers in Black patients for preventing stroke and heart failure that was not seen with ACE inhibitor monotherapy. This continued to be the recommendation as guidelines were updated. Despite this guideline having been widely followed for many years, non-Hispanic Black patients in the U.S. still have the greatest level of uncontrolled stage 1 and stage 2 hypertension compared to other racial groups. This can result in devastating consequences, including stroke, chronic kidney disease, and heart failure. Uncontrolled hypertension often requires treatment with multiple medications, and guidelines are now beginning to recommend initial combination therapy, including an ACE inhibitor or ARB, along with a thiazide diuretic or calcium channel blocker, regardless of race. Considering the racial distribution and persistently high rate of uncontrolled hypertension despite treatment, it is worth reevaluating the underlying factors that impact both disease and treatment efficacy to further improve patient care.